So I would now invite the chairpersons of the next session, Dr. Milind Merchant and Dr. Shailendra Verlekar, to take the stage and invite the conveners to start the next session. Okay. So Dr. Amol Gharote and Dr. Milind Merchant, please take the stage to start the next session.
The one thing which is most precious in Wiroc is time. So for want of time, we'll cut the formalities. I'll also request everybody who's honored us by their presence, come ahead. You may want to hold the mic and talk to us, because this is a session on billing, right? Why are we doing all this academics? It's order to earn enough money out of all the academics. Okay, so Dr. Ghosh has very kindly joined us on Zoom. He is a little unwell, and the rest of our panelists, esteemed panelists, I will invite everybody to join us. So Dr. Hardik Ajmera, Arti Raichura madam, Mohan Joshi sir, Alfven Viera sir, Prakash Gudsoorkar. I'll just briefly introduce all of them. Dr. Ghosh represents the insurance. He is from a private insurance, Aditya Birla. Hardik Ajmera represents the corporate world. He is from Saifi Hospital. Dr. Dwivedi is my co-convener for the session. Dr. Prakash Gudsoorkar here is the head of Department of Orthopedics at Dhavle Hospital, Palghar. He will represent the face of rural Maharashtra. Dr. Mohan Joshi sir is the Dean of SIAN. He represents teaching establishment and academia. And of course, our chairpersons will also be contributing to the discussion. So quickly, I'll just upload this PowerPoint to generate excitement and to get some insight into what is happening in the billing world, right? So we ran a survey and we asked people who were registered for Wiroc whether you own a hospital or not. So this shows that substantial number of people own their own hospital, 42.9%. So then we took the hospital owners and we asked whether you have cashless insurance. So a bulk of people have cashless insurance, and we ask them who earns more. So they obviously feel the corporate cashless people are earning more. Then we ask them that do you prefer having cashless patients? So very few people, only 14% of the people who own hospitals actually like to cater to cashless insurance patient. Then we ask them whether you can differentiate between private and nationalized insurance. So 80% felt that private insurance players are better. Does the money match your expectations? So look here, 60% people feel that the money is not matching their expectation. 64% people feel that the money comes in very late as 90 days. The admission and discharge process is delayed by insurance. Overwhelmingly, 82% say that yes. Where do you think cashless works best? They agree it works best in surgery, but they are unhappy about the terms and conditions. Okay, and the lead question, would you keep GIPSA packages at your hospital if given a choice? Everybody wants to say, no, I would not want to keep the GIPSA packages. Does cashless promote wrongful billing headings? So they feel, yes, it does promote wrongful billing headings. Okay, but do you think cashless is the way of the future? Overwhelmingly, majority says, yes, cashless is the way of the future. So now, freelance consultants, none better. They don't want to have GIPSA. They are very unhappy with the GIPSA and the insurance players. Only 10% of freelance consultants say that they would like to treat cashless patients. And they say over 90 days before the money comes into their account. So people are unhappy with insurance, and that's why this session is happening. How to achieve harmony between surgeon, their surgical charges, and between the insurance companies. So the money does not match their expectation. Admission process is delayed. It's the same story repeated for freelance consultants. We ran a small survey as to what is the minimum amount of money that an orthopedic surgeon would settle for a total knee replacement in a corporate hospital in GIPSA package. And an overwhelming 81% people feel that they should get at least 30 to 50,000 rupees net in hand after affiliation and taxes. Is this happening? So this is not really happening, and people are very unhappy. So now with this unhappy case scenario, I'll first ask Dr. Ajmera, who himself is an orthopedic surgeon. I have had a lot of discussion with him before also on this, how the corporate world is handling this GIPSA pressure and this unhappy consultants. And if you could restrict it to orthopedic practice, because our audience is orthopedics.
Good afternoon, everyone. Thank you, Dr. Tushar and team Wiroc for inviting me here for this session. So when it comes to insurance and especially cashless insurance, as you rightly mentioned, there are 4 stakeholders. One obviously is the patient. Patient wants good infrastructure and good doctors at a cost which is affordable to them, and also would like to reap the benefits of cashless scheme. The other stakeholder obviously is the insurance company, who want that their outgo payout should be less than their premiums what they receive. The third stakeholder is the doctor. Very importantly, the doctor wants a good infrastructure which a hospital can provide for his patient, and at the same time, doctor rightly would like to command fees for his skill, okay, which the insurance company is trying to restrict. Okay, in a needy patient, no doctor would deny a treatment, but like any other sector, the top specialist of any field would command his fee, which is being trying to be capped. The fourth stakeholder in this entire game is the hospital, like a corporate hospital like ours, who has to do a very delicate balancing act of keeping the patient and the doctors both happy. Because not only patients are my real patients, even my consultants are my internal customers. They are the ones who also bring the patients to my hospital. So when I try to make the healthcare affordable for the needy or for a set of patients who can also pay, at the same time, I need to make sure that I also provide the doctors with the right remuneration for their skill sets. Now, while trying to achieve this delicate balance is what my hospital like us and all other hospitals need to position themselves. That is where the choice is coming, whether they want GIPSA or they don't want GIPSA, because of its advantages as well as disadvantages. So when
I'll
we come
just
to
interrupt here. From your experience, what do you feel? Bulk of the people have a GIPSA insurance or they don't have GIPSA insurance?
You mean bulk of the hospitals?
Bulk of the patients who come.
Yeah. So all individual policy holders would definitely fall under GIPSA insurance. Okay. However, that is what when we discuss the topic of positioning yourself, you have to decide what suits you, accepting GIPSA or not accepting GIPSA. And no answer would be wrong depending on your geographical location, on your set of skills, what you are providing, and your hospital economy and your set of doctors.
Right. Perfect. So the gist here is we can't fight cashless insurance. We will have to decide for ourselves what is our patient load, what is our skill set, and where are we placed. Right. Sir, if I may say, not with a sort of a communal intent, but you are from SEFI. So do you find that a bulk of your clients are uninsured and therefore the hospital sustains its work?
Okay, so before that I will let you know that we have, for a reason, we have taken our call and not accepted GIPSA as of now. However, being a community hospital is not an important factor in this decision, because only 20% of my patient mix is from the community. Rest 80% of the patients are from all other communities like any other hospital. So that doesn't play an important role in our decision making, but there are other important factors which we can discuss in the session going forward.
So the myth got cleared. SEFI hospital has only 20% from the community. So they do cater a large number to the insured sector. Right? But in fact, I discussed with Dr. Hardik and he says his consultants are very happy because they are able to bill outside of the GIPSA package.
They have the right to charge. Their remuneration for their skills in the higher category.
Yeah. So they have a say in how much they are charging, right? Now, Arti madam, I'll quickly come to you. Arti madam runs same sort of service for small to mid-sized hospitals in the suburb. So, madam, आप बताएं, what is the list of problems and woes that problems, like I own a hospital, so 25-bedded hospital. What are the list of problems you feel we are facing?
Yes, sir. Good afternoon, sir, and thank you for inviting. The main problem nowadays in suburb, I can say a 50-bedded or a less than 50-bedded hospitals are facing. That is the main problem, rate revision. Since the day of they have done the empanelment, GIPSA has not revised the rate since last 2-3 years because of one or the other reasons. Also, they renegotiate. Nowadays, they are asking discount on implant also, on medicines also. Even they have created certain packages for medical management, like for dengue or any kind of acute febrile illness or such kind of disease. They have created the packages. So you have to prepare bill accordingly. That you have a limited package or amount. You have to fit your resources accordingly. And the main is threats. They give the threats related to de-empanelment. Anyhow, they find one or the other reason for de-empanelment, whether they find some sort of billing or maybe presentation problems or something like that. Even
So, madam, एक second. So, ये तो सारी complaints हो गई. So, I want to know, हमारे पास कुछ solution है क्या? Ajmera sir, Arti sir, if you do both, madam, if you will tell. Because सब मुझे पूछ रहे हैं कि ये तू बात करने वाला है problem की, solution क्या है?
Yes, sir, we have a solution. As Ajmera sir has already said that what is our own vision, we have to first clarify that. In our hospital, if our objective is to cater a volume, then of course it is not possible without GIPSA. So if you are in that particular category, if you are looking for a person who is, other consultant who is going to come and operate in your hospital, and if you have a GIPSA, and if you are thinking that after GIPSA my volume has increased, then definitely it's a volume game. You have to survive as per the rates only, and sometimes you have to prepare bill as per the surgeries, means you have to split the surgeries. You cannot charge only for one surgery. You have to divide surgeries, maybe if it is genuine or if you can justify that particular surgery.
No, that is done. Now,
Yes, sir.
let us say, how do you decide the profit sharing? Yeah.
No, sorry, I was trying to answer your previous
Yeah,
question.
the problem,
Is there
how
any
to deal
solution?
with the, yeah.
Okay, the solution is very clear. GIPSA or cashless is one of the factors or the benefits what the patient is looking for. But you are selling your product or your service based on other parameters. If you are a fantastic surgeon, if you are a very good hospital, if your services are top notch, like us, all your patients will pay to you and then go for reimbursement even if they are insured. That is what you have to do, the act of balancing. If you don't want GIPSA to be the bottleneck, you have to raise the bar for all your services. And
So, what sir was trying to tell us is that the ball comes back to us. So, तन्ना सर को फर्क नहीं पड़ता, मतलब पेशेंट कैशलेस में जाएगा, जिप्सा में जाएगा, पेशेंट को तो तन्ना सर से ही ऑपरेट करवाना है. So I guess we have to raise our ballpoint park to that level, and if it's not there, and if we are losing patients, then we have to probably adjust to what the GIPSA is offering. एक क्वेश्चन इसी संदर्भ में, सर का हॉस्पिटल है where he is the orthopedic surgeon and wife is gynecologist. The gynec rates are very bad. Many people in our audience would want to know whether we can, मैडम आरती मैडम आपसे पूछ रहा हूँ कि सिर्फ ऑर्थो के लिए जिप्सा पैकेज ले सकते हैं और गायनेक के लिए नहीं अलाउड होगा इनके हॉस्पिटल में. Is that
But
sort
it
of?
is not like that. If you have a facility in-house and if you have a in-house doctor, whatever services you are offering, you have to take that entire services. You cannot say, I cannot
So,
take
मतलब ये
GIPSA for
gynec refuse
gynec.
नहीं कर पाएंगे
No, no,
GIPSA.
not at all, sir. You have to serve that particular service also.
And sir, आपसे as head of academic institution, sir, and also you've been in practice. So right now I want to ask you, what is your opinion about all this rigmarole which is happening on insurance?
Far as now as a dean I am concerned, in the free hospital or university hospital setup, we are dealing with Mahatma Jyotiba Phule Yojana and the Prime Minister's Yojana. And since our doctors are paid by the hospital, rest of the services are paid, we are able to offer in orthopedic practice the best possible implants and the best possible stents probably in free setup because there are no other expenditures. So we try to exhaust XYZ money, which is given for that particular, surgery. We use it. But when I was in private practice, when I was a professor and head department of surgery, that time I used to find that this is too complex procedure. So, but in a vast practice, it hardly matters. The concern to me is not how much you are earning, because as such, when even I was in private practice, I was working, on a fixed salary in Sion Hospital. So I used to say that suppose I operate X patient in Sion Hospital, I will get zero money, and I am getting some money. So I used to be happy. So that is not the concern, but the concern is now the medical legal issues, which the responsibilities which you are facing, then that insurance company, anything which is happening, unless you have good understanding with the patient and the patient has faith on you, it becomes sometimes difficult. Any complication which comes up in a intestinal surgery, in a given surgery, which is always possible, then that is not supported and the patient is solely dependent on his mediclaim. So that becomes a problem, and the things are very
Especially
cut
if
to
the
cut.
if the insurance amount is very small.
yeah,
Right. So one question I have to everybody is that, or rather, Dr. Ghosh, can you hear me? Can you hear us? So the question that I'm wanting to ask is that we have a patient who has an insurance of 2 lakh rupees and then we have a patient who has an insurance of 10 lakh rupees. So why should the charges for a prescribed surgery rise only by 10, 15 or 25% when the patient's insurance is 10 lakh rupees? So if Dr. Ghosh could hear us, maybe he would want to answer us. But while we are getting connected to him, since we discussed the MJPJY, my friend Dr. Alfven, who is head of one of the largest private medical college ortho department today at MGM Medical College, Navi Mumbai. So I would want to ask you your opinion on this MJPJY and all these other schemes which are working at our hospital at MGM, and how has it benefited the department?
Good evening, everyone. I thank Team Wiroc and Dr. Tushar for giving me an opportunity today. Now, as far as your question is concerned, it has helped. I belong to a setup of I belong to a trust hospital, which is a medical college. Now, as far as these government schemes are concerned, we cater to a different class of patients actually. Now we will cater to lower middle class and the poor actually. So in that, it helps us a lot as far as volume is concerned. Now MJPJY scheme or PMJY scheme or even the CGHS is beneficial to us because ours is a teaching hospital. No doubt for a long bone fixation we get only 20,000, wherein we have to adjust the implant as well as the medicines. Now as we belong to the medical college staff, we are paid a salary. We don't get anything out of it. But anyway, a large section of the patient is benefited, specifically the poor. And it gives us a lot of learning volume for our students. Now, for us, we have 14 postgraduate per 11.
I'll interrupt you here. I am a part of that department. So I want to ask you, does it cause more paperwork burden on your houseman register? In terms of photography and all that, or is it okay, acceptable?
Now we have a team for the other things, like doing the paperwork, taking the pre-authorization, that team is there. But our resident's job is also that he has to see that everything is done, plus he has to see right proper diagnosis, because if anything goes amiss, then it gets rejected. That stress is there.
Yeah, so the documentation onus is on us.
Us. Because then there is a Arogya Mitra also, who tries to, from the government side.
I'll quickly go to Prakash now. So Prakash, you are the head of department of a trust hospital. I happen to be working there and I've seen the functioning. So now they are a medical college, they are training postgraduates, so they are benefited. Is your hospital benefited by the MJPJY scheme, or actually it is cannibalizing into the profit of the trust hospital?
Good evening and thank you for the opportunity. Being in a rural setup and in a trust hospital, which is a private NGO sort of, the hospital income is actually getting cannibalized into it because none of the consultants are paid or employed there. They are on the sharing basis. And the MJPJY hardly, so as sir mentioned, it is 20,000, but that is in a class A category. Now ours comes into B category, so our rates are not as 20,000. They are still lower than that, and they get shared. And in that we have to adjust the implant medicine and the consultant and the hospital share out of it. So it is getting cannibalized into it, and the solution for that we have made is MJPJY doesn't bar you from taking donations. So since it is a private NGO, we are allowed to take donations from the donors and CSR funds. So we have adjusted to that. So we all are benefited into it, but purely MJPJY is not beneficial. Absolutely for a private hospital where the surgeon is employed and hospital is also earning out of it. In Palghar setup, it's almost 75% people are holding below poverty ration card. So everyone who is coming out dashes out the yellow ration card. So we have to cater them free.
Can you hear us?
And plus we have to give money to go home also.
So what Prakash is saying is that because he is running a trust hospital and he is also dependent upon the donor income.
Donor.
And because the CSR funds are coming, so he is able to afford. So I used to travel a lot for pediatric orthopedics all over the state. And a lot of small nursing homes used to go for these government schemes. So it's very tough, and they have eventually left because it's not feasible and viable. But sir, you would definitely feel, sir, Dr. Joshi sir, that it has helped tremendously in
Now
terms of volume, patients.
My outlook is like this, that somebody gives, a loan for the motorcycle. The motorcycle owner is not in a position to, have even a motorcycle, but he meets with an accident. And then that person needs some support. In the initial period, when we are fixing the fractures and all that, we had to write to several trusts and collect the money which are required for the implant. So now what is happening is that we just pass on the papers across, and we get sanctions that XYZ money is sanctioned. And then we are able to
Sir, can I
run the
interrupt?
show.
Sir,
Yeah.
in how much time is the money realized? Do we have any rough idea from the government schemes?
It's really not, as and when the money is realized,
But
we
it comes.
pay the vendors.
Yeah.
I don't think, in fact, we have large amount of surplus money to the tune of, say, at this moment we have a separate account for this. We have about 30 to 40 crore rupees which are in that money, which are over and above XYZ surgery, which we have been able to save. But we don't have the ability to do something called as cross subsidy or to help out other patients. So that remains sometimes unutilized. So that is not the thing. But practically, for a patient who comes for a cardiac bypass, for a patient who comes for a angioplasty, he had to wander at several places, collect the donations. Now that is over. If he has a brown card, if he has a yellow card, and if he is not a Bangladeshi, that means that if he is holding a proper Aadhaar card and legitimate Indian citizenship, I think that the things are done very well. The number of angioplasties which we do, the number of complex angioplasties which we do, the number of balloon interventions in cardiology which we do, and the amount of fixators and the fixations which we are using have raised phenomenally.
सर बता रहे हैं कि जो एक्सपेंसिव सर्जरीज हैं, जो इम्प्लांट बेस्ड मटेरियल बेस्ड सर्जरीज हैं, they have really benefited a lot vis-a-vis from the time where we were. Dr. Ghosh, can you hear us? Dr. Ghosh.
I can hear you.
Yeah, great. So tell us, sir, you were wanting to tell us how different are the private players in the insurance versus the GIPSA players. If you can tell your bit on this. And as you can hear from the conversation and the interested audience, most of the people are very disillusioned with this insurance business. What I had discussed with many surgeons is that nobody here is greedy, right? But everybody wants to have a certain say in what they are being remunerated. You know, an orthopedic surgeon wants a certain say. Let's say तन्ना सर ने डिसाइड किया कि मुझे इसका सर्जरी 20,000 में करना है, तो दैट इज तन्ना सर शुड हैव द फ्रीडम. इंश्योरेंस कंपनी शुड नॉट टेल देम कि नहीं आपको ये 20,000 में ही करना पड़ेगा. सो दे आर अनहैप्पी अबाउट दैट. सो थोड़ा बहुत प्लीज टेल अस ऑन दिस. How to make the doctor fraternity, the hospital fraternity and the insurance fraternity, all three happy? Is it ever going to be possible?
Yeah. First of all, thanks Wiroc, thanks Dr. Fadnavis, and thank you Dr. Tushar, and thanks Bombay Orthopedic Association. I personally wanted to be there, but yesterday got heavy fever and there's a slight chance that I may be having COVID, so I could not be there. So I heard the entire group, and being in this industry for so long, this is a constant problem which we have been hearing. If I am permitted to share my screen, I thought I'll try to show the entire fraternity of the community that what exactly the things look like. Can you see my screen?
Yeah, it's visible, sir.
Yeah. So, just to give few perspectives to all my fellow orthopedicians, I wanted to share that how the exactly health insurance community has grown. And this is the IIDA report. So, we as an insurance industry are governed by a regulator. There is no governance body for any hospital or actually for any doctor, but for the insurance industry, there is a governing body called as IRDAI. And this is the slides which I'm showing from their annual report. Currently, this is a 73,000 crore industry. I'm talking about the last financial year closing figure. This includes the public, private, and the standalone. The standalone are those companies which are giving only health insurance cover. The private or the public sector are those companies which are having health insurance plus other insurance like motor, fire, and so on. So, first of all, let's...
Dr. Ghosh,
Ghosh,
sorry to interrupt you. We would be hard pressed for time since you are not here. So, we've got 12 minutes into this session. So, if you can just sort of summarize and tell me what are we getting to? Means private players, government insurance players, hospitals and doctors. Are we ever going to be symbiotic, or are we going to keep cannibalizing into each other?
No, we can only be symbiotic if we understand what are the pain points of each other. Currently, for example, if you...
So please tell us the pain point of the insurance company.
Absolutely. Actually, through this survey, I was trying the slides which I was trying to show. So I was trying to come to that point only. The major pain point for any insurance company is that, see, we all collect premium. Okay. And if our losses are very high, then there is a fundamental problem that we will believe that there is some problem overall going on in the industry. So this is a slide which I want to show that this is the current status of the health insurance industry. If you see the losses, so the claim ratio means the losses which we are incurring. If we are taking a 100 rupee premium from somebody, we are already paying more than 100 rupee. This means, number one, there is a premium mismatch. How does insurance work? So if you see, all the various companies or the industry is working in about more than 100% of the loss ratio. This is the biggest problem.
So can I interrupt here? Again, I'll interrupt. So is the insurance sector becoming like the airline sector? So it is necessary, but we can't make money?
It's not about making money, but it's about the fact that basis what parameters the premium was calculated. At the end of the day, there is a data available in the market which shows that for X disease, for X surgery, this is the amount which has been charged by the various fraternities, which includes the ortho community also. So now if somebody wants to jack up the rates or hike the rates, there has to be a logic given to this. Currently what is happening, just like the survey which was done, the survey would have been much better if a blank was given that what do you expect as a remuneration for your surgery. If we give a output that if I want 15 to 20K or 30 to 50K, or let's say, obviously everyone will select the highest amount. So this is where the problem comes. There is a rich data available with the insurance industry that what should be the cost of surgery.
Excuse me, sir. So what Dr. Ghosh is saying is that there is a benchmark rate. So Dr. Shiva wants to ask a question, make a comment.
Quickly, I'll ask questions. So, if the rate of MPJY
So
or
the question is addressed to
yeah, question is addressed to general.
everybody.
PMJY or MPJY is same for private and government. In a private, the person pays for the salary, person pays for the land, person pays for the tax and everything. There should be at least government plus extra should be given to private players so that large
sir,
benefit will.
So sir is making a comment here
Yeah.
and not really asking a question
no,
that if we want,
they are the
if
deciding
private
people.
players want to
Yeah.
have MJPJY,
Yes.
what should we do?
That's the reason it is promoting substandard treatment, to tell frankly. On an open forum, I'm going to tell. Because in 20,000 rupees, if you ask any private player to operate on a femur, he has to do cost cutting somewhere. So that is what is happening. That's what I'm.
So sir, Dr. Abhijeet, so the statement which people want to make is that somebody like Professor Shiva or Dr. Tanna, they cannot be evaluated on benchmark, right? So they are way above the benchmark. So if they are going to, if somebody who's got 60 years into practice cannot be charging at the same rate who has 6 months into practice, so how does the insurance company account for the experience of the operating surgeon? You got my question?
Yes, I got your question. Currently, so we would have to bifurcate this into two categories. One is something which is government dominated, which is like PMJY and all. And the other is something which is the insurance company related. Both the rates more or less are not similar and they have various different parameters.
No, right now let's talk about your insurance company. So
Yeah.
now if you have to settle a claim whereby Dr. Tanna is operating and let's say a surgeon who's just passed MS and he's doing a TCAR. Now Tanna sir would need to make X amount of bill and the new guy is happy with whatever bill is coming. So how do we account for the experience of a surgeon?
So
Means let's say
currently-
for yourself, means you would want to choose the senior most surgeon to get operated, wouldn't you?
Absolutely.
And
There-
then how does your insurance account for it? Everybody wants to go to the best hospital, have the best surgeon, and then want them to just go ahead with the GIPSA package and pay 2.5 lakh rupees. Sir wants to say, Dr. Mohan Joshi wants to opine on this.
First is that everywhere in all over the world, any insurance package, the patient and the doctors and the hospitals are not ordinarily happy. I have seen situations in USA where the insurance is over for ICU, so at middle of the night after the angioplasty, somebody is discharged. Or despite that now the insurance package is over, so you need to wait. And somewhere in US, I have seen that what is happening is corridor delivery, because they feel that the patient is admitted, the patient should deliver within a span of certain number of days, and the patient should go away. But car deliveries and corridor deliveries in the hospital are happening because they are scared of insurance that they will not reimburse and the patient will not pay. So overall, the insurance scenario all over the world is not a very happy. Number two, that all the doctors have to remember that insurance companies, whichever are there, are not charity trusts. They are making their own money. The standard of medical treatment has increased significantly, and therefore the cost of medical treatment has increased significantly. However, nobody is able to pay the realistic, what is called as premium. So that is also important. Now they have graded hospital. Hinduja gets one package for appendicectomy, and XYZ Fortis gets second package, and the third package is offered to, say, a small Sai hospital in Dharavi. So that is different. Now if they start grading surgeons, we know that Dr. Tanna has been our teacher and Dr. Tanna used to do very good surgery. But every senior surgeon or an old surgeon doesn't mean that he is a good quality surgeon. That also needs to be kept in the mind. So hospital grading, grade 1, grade 2, grade 3 or ABC, plus grading of the surgeon on what ground, it will become a very complex issue. What we need to understand is that as far as the government schemes are concerned, that is Prime Minister's scheme as well as Mahatma Jyotiba Phule scheme, these are the two schemes which are functional in Maharashtra state widely, they should increase. The government is not spending as much on the health budget, so they should increase their expenditure on these schemes, number one. Number two, that the solution is that large amount of CSR money is there. The government has mandated every profit-making organization to spend 2% of their money. So they can divert that money to the scheme instead of leaving that to the liberty of the person who is wanting to spend CSR. So if they say that 2% of the money has to go, if the government doesn't have adequate revenue, if the 2% money has to go on CSR, 1% should come to this particular scheme. So the scheme is boosted up and the amount of money which the scheme would like to spend on a particular patient can increase. But it is very difficult. It is very difficult. What we need sometimes is that, of course, that Mahatma Jyotiba Phule scheme is limited to 1.5 lakhs of insurance. And there are certain things where we are putting advanced devices, diverters, etc. in neuro sciences. And what we need is the cost is 7.5 lakhs and some companies have, monopolized the
Pricing.
stents, pricing and the stents. So we need to support from various other CSRs or something. But what we need to do is government should increase the revenue expenditure.
Superb point. Just a second, sir. So the point what sir made is that the individual does not want to spend the money on his healthcare. We have insurance players who want to make money themselves. We have CSR funds and we have government funds. Sir says the clear solution to this is that the CSR fund should be well directed to the government insurance scheme, and therefore the lower strata of the society is automatically taken care of without burdening the insurance care system. So the premium system will get horizontalized. So it's a wonderful insight. Means I was worried that I'll have this session without a single clear idea of where we should head. Sir, what were you wanting to say?
Again, MPGA has become a standard now, such a low rate as insurance. Even all the other insurance companies will bring down one day or the other, and they will, when Tushar, you are operating under MPGA at to 20,000 rupees for fracture, fever. No. Why you are operating with my United Insurer, my GIPSA scheme for 1 lakh rupees. So they will bring down, already it has happened in Karnataka. 6 insurance companies have come together and they've given representation to Karnataka saying that when in Yashaswini scheme, when you can operate at 30,000 rupees, why this hospital or why this Dr. Tushar is charging so much to us?
So it's a very clear picture. Not a single private consultant or establishment should take MJPJ, because that will destroy the basic down benchmark of our healthcare cost. Dr. Hardik wanted to say something.
So I will to answer your question that is there any...
We've got 2 minutes left.
Take 1 minute. Is there any gradation in the insurance scheme to pay out to the surgeons based on the seniority? Unfortunately, it's nothing. So I will just start by continue where I stopped at the start of the lecture, that if you are a good doctor, good patient following and good infrastructure you have, you don't need any insurance and you should provide your service or your product at your own cost and not at a cost dictated by the insurance company. Now this
and also then not be worried that 10% patients will go away.
Let them go away, you will get 30% more patients based on your skills. Now this is a non-confrontational solution. There are
so 1 second, so I'll just tell this. So the other solution, yes sir, just 1 second. So the solution, that second solution is coming, is that stick to your charges. Don't worry about the patients who go away. You will get enough number of patients.
It doesn't happen.
Sir, you want to make a comment? उधर माइक देखिए सर, आप बोलिए ना तब तक.
I am insured for 20 lakh rupees, but the insurance company says that no, you should. I am going to only reimburse 20,000 rupees to your. Say, one of my friend recently got cataract surgery done. He is insured for 20 lakh rupees, but he was only given 15,000 rupees when the lens itself costed him something like 75,000 rupees. The insurance company refused, saying that you are in this scheme you cannot give.
Tushar, what you are saying is not possible because
can I talk now?
The hospital in which you work, if it is empaneled under cashless, you cannot refuse the patient cashless facility. So you cannot say that you charge your own fees and
No,
you
no,
have
no,
to
no.
do that.
One
It
second.
is
One
illegal
second.
to do that.
One second, Sandeep. I discussed it with him. You will have to shift the patient somewhere else if you want to charge, which is not empaneled under cashless. Sir, what do you want to say?
I want to say that what Madam has brought out, Arti Madam, that GIPSA rates have not been revised for last 3 years, in spite of multiple.
Madam, how do you think
How
we
do
can...
see inflation has gone and revision has not taken place?
Yeah, this
How
is
to
a very
go about?
good question, sir. But what I am feeling that there is a lack of unity between the doctors and the hospitals. If we all are one, then we all can go at a one time and can approach to a insurance company. Then there will not be any chance कि वो लोग revise नहीं करेंगे. But एक नहीं करेगा तो दूसरा ready है, दूसरा उससे कम में भी करने ready है. This is the problem we are facing nowadays, and because of that, GIPSA is taking advantage of all these things.
So our own hospital, GIPSA revised the rate by 10% and they increased the MOU discount from 10% to 20%. So in effect, we will get lesser than what we were with the old MOU.
Very true, sir.
This is a reality.
This I also have faced the same things, but it is completely
your
upon
comment,
us
sir?
to accept or not the GIPSA rates.
We all are having take-home messages from here. My request to the insurance companies is a take-home message for you. Can all the CEOs of all the companies and all the employees come at the same payment package across the country? Can you dictate your pay per se, or are you getting pay as per your seniority? The more senior the person, the more senior the CEO, the more pay you're getting. But the doctors don't deserve more pay when they are becoming seniors. So why don't you come at a pay parity?
Well, that is because the patients don't want to pay the doctors. So...
No, but they
the
can come at
problem
pay parity for the benefit of the patient, no?
If
When
you
they
allow
come
me
at
to
the pay
speak for
parity...
2 minutes.
One second. So, Prakash, what do you want to say?
There was one comment that we should not empanel MPJY. In fact, we were the very last person, or we were the first, but nobody in our district was getting empaneled into MPJY or any scheme. Local MLAs and civil surgeon was pressurizing and arm twisting us for the registration that you are the biggest hospital here, but you are not empaneling. So these inside tactics were going on. So ultimately we were forced to empanel MPJY, but we devised a way in the CSR which is functioning well, and we are happy with it.
So Tushar, if they take care of their pay, the claim ratio is going to come down. The insurance payout will come down. And that figures which Dr. Ghosh showed will actually come down in a very nice way. So please take care of that also.
So in the interest of time, we will just stop the session. I am glad so many people spoke up. I don't think we have a defined solution to this. I am so thankful, first of all, to Dean sir, because he really had real no purpose other than helping us out. And you know, sir, we are deeply grateful from Wiroc and from everybody is here. And all my friends and colleagues who have joined, the chairpersons who discussed with me, I tried to highlight their points, my co-convener, Dr. Dwivedi, and above all, the entire audience. I hope every Wiroc has a session like this and we are able to annually sort of highlight what problems we have faced in the past year with different set of panelists and then eventually sort of thrash our problems. But I think our final conclusion is let us stay united. Let us not undercut each other in charges. If that at all,
Can I say
get more CSR funding into
Tushar,
government schemes.
Can I say one thing?
Yeah, please, sir, please.
Yeah, I just want to say this to the entire community. See, everyone wants patients' betterment, even insurance company. First of all, please have that faith. And if you work with insurance company together, I think it will be a much better solution. Your volume will also increase and they will also be comfortable that it is not getting abused. So if you, from my side, if the take home has to be there, I would just request you, if you can show that here, misbilling, mischarging, overcharging is not happening, any insurance company will help you. That is one comfort I want to give to the entire group.
Let us work symbiotically and not cannibalize into each other. For the time being, for this session, we'll conclude with that. Thank you. Thank you very much, everybody. Thank you very much.
Sir.
Thank you.